Good morning and welcome everyone to today's webinar hosted by the Schuyler Center for Analysis and Advocacy and the Postpartum Resource Center of New York. My name is Bridget Walsh and I am the Senior Policy Analyst at the Schuyler Center. We are going to begin the program in just a few minutes, but in the meantime we want to get to know our audience a little better. So you're going to see 3 poll questions up here. Please note that these questions are optional, but if you do decide to participate in any of the poll questions today, your answers are anonymous. The results of the polls will be shared during the webinar today, just as a way for us to understand who is joining us. So in a minute, you're going to, there you go, some poll questions.
Hi everyone, I'm going to leave the poll up for just about a minute, just to give everyone who decides to answer a minute to answer these. We actually have quite a few people who just jumped on, so I'm going to leave this up for about 20 more seconds or so if they decide to answer these. Okay, great. I'm going to end this poll and share the results. And I'll leave these up for about 15-20 seconds just so we can get an idea of who's here today. All right, great. Thank you, guys.
Good morning again. The Schuyler Center is excited to offer this presentation in the Moving on Maternal Depression webinar series in collaboration with the Postpartum Resource Center of New York. The Schuyler Center is a statewide, nonpartisan advocacy organization primarily focused on improving policies for those living in poverty, particularly children and families. The Moving on Maternal Depression project work is part of our continuing efforts to connect and improve care and resources for pregnant and parenting women and their children. This project, the MomD project, was part of a national learning collaborative to advance policies that improve prevention, screening, and treatment with an emphasis on racial equity and culturally relevant practices in policies and systems. Here in New York, we expanded the focus to include maternal mental health more broadly. While the national project has wrapped up, we hope to develop a state-level learning collaborative that can share best practices and information on maternal mental health issues here in New York. At this point, I'm going to introduce Brittany Eskew at the Schuyler Center. She's the voice you're hearing doing the polls. And so I'll have Brittany say hi, and she's going to be available in the chat for any technical questions you may have.
Hi everyone, it's Brittany again. I'll be working on the polls as Bridget mentioned, and I'm here for any technical issues. If you have any hearing issues or anything that's coming up with the program, just put it in the chat and I'll be there to help.
Great, thank you. So at this point, I'm going to turn it over to Sonia Murdoch, who will introduce the Postpartum Resource Center of New York and our speaker for today.
Thanks, Bridget. I'm Sonia Murdoch, the Executive Director and co-founder of the Postpartum Resource Center of New York. The Postpartum Resource Center of New York has been helping New York State moms, dads, and families get to the help they need for perinatal mood and anxiety disorders since 1998. Our statewide toll-free helpline is available 7 days a week, with additional support from our Moms on Call and family telephone support. Online, we have a free access to the statewide perinatal mood and anxiety disorders directory. We also offer through our training institute, including training on our Circle of Caring support group program and various initiatives such as our Project 62, Lisa Mary Riley Visioning Educational Series, and the Take Care of You initiative. If you would have any questions regarding more specific services that we offer, please let me know at the end of the presentation today. This webinar is approved for one continuing education unit for New York State licensed social workers and New York State licensed mental health counselors at a cost of $15. Helping Hand Psychotherapy is recognized by the New York State Education Department's State Board for Social Work as an approved provider of continuing education for licensed social workers, and by the State Board for Mental Health Practitioners as an approved provider of continuing education for licensed mental health counselors. So at this time, Brittany will post the link in the chat for those who'd like to take part in the CE unit. So thank you, Brittany. So before we introduce our speaker, we'd also like to ask 2 more poll questions. And remember that these questions are optional and anonymous. The answers to these questions will be displayed for the audience to see. So thank you for answering them if you choose to.
Thanks, Sonia. I'm going to leave this poll up for about 30-40 seconds. Don't want to cut into too much of Melissa's time. Okay, great. I'm going to end this poll and share the results. And we'll just leave this up for just a few seconds here. Great, thank you guys so much.
Thank you, and thanks, Brittany. So I'm excited to introduce everyone to our speaker today, Melissa Passarelli. Melissa serves as the Director of Programs at Docs for Tots, where she oversees the development and implementation of their projects, including Help Me Grow Long Island and their initiatives for developmental maternal depression and ACEs screening. Melissa has a Master's of Arts degree in International Disaster Psychology from the University of Denver and trained as a trauma therapist and disaster responder with refugees, homeless women, and children, and survivors of sexual assault, both domestically and internationally. And she helped establish and coordinate the Trauma and Disaster Recovery Clinic in Denver, Colorado. And working with Melissa and Docs for Tots for the past few years, it's wonderful to welcome her here today for our webinar series to share about Docs for Tots and their work. So thank you, Melissa, for being with us today. And now I'd like to invite you to share your screen. Thank you.
Thank you so much for having me. I'm so pleased to be here. We call this project and this talk, Well Moms, Well Tots. It's about maternal depression screening and how we've helped implement it in pediatric primary care, although the lessons are applicable across specialties. And I'll speak a little bit more to that, but we have experience doing practice transformation in different settings, and all of the lessons kind of stay the same. So if it's a little too medical for you, I hope that you don't shy away from that. But our goals for today's session are to understand the approach that we take at Docs for Tots, learn the methods of evaluation that we use to measure the progress, and explore barriers to implementing change and ways to overcome them. So about me, I know that my bio was just read. I do have a master's in international disaster psychology. So I trained as a trauma therapist with really special attention to cross-cultural manifestations of trauma, but we really also focused on a public health approach to integrate considerations about mental health across societal systems. The biggest thing that we were taught is that you can't be your own thing, you have to have a seat at the table. And so this background has really served me well at Docs for Tots for the past 7 years. Docs for Tots is a pediatrician-led nonprofit that focuses on improving outcomes prenatally through age 5. But rather than working directly with children and families, we work with the adults that serve those children and families. So the idea is that we work across existing systems. So, pediatric providers or other health providers, social service providers, policymakers to try to implement best practices, because we know there's so much research that supports the importance of early childhood and strategies to implement, but day to day, it's really hard for professionals to put those strategies into practice. So the two methods that we take to do this are practice transformation and system change. So in practice transformation, which is what I'm going to highlight today, is really looking at how we can work with, in this case, pediatric offices, but we've also done it with childcare providers, WIC providers, other, social service providers. How can we implement best practice in a way that's meaningful and sustainable for lasting success at those sites? And then systems change. So how can we take what we know about what we are seeing on the ground level and bring that up to help influence the policy that supports those ground level changes across the spectrum? So the way that we got into our maternal depression screening project was our initial developmental screening project. So just brief background, developmental screening is using a standardized tool to detect developmental delay. It's really critical to do this several times in the first years of life so that we can try to catch and address developmental delays before a child gets to school. But we know that most physicians have a hard time doing this, and in fact, New York State ranks one of the last in the states in the country for our developmental screening practices. So a few years ago, we had a project where we worked with 6 pediatric practices to integrate standardized developmental screening at the ages that were recommended by the American Academy of Pediatrics. And we did this by integrating screening into all aspects of the well visit workflow, which I'm going to explain. So we came in with an intervention model planned, but this was a quality improvement project, and so we adapted it as we went based on the feedback that we were getting and what we were seeing. As a result of that project, during the project period, over 1,000 screens were given, which led to 100 referrals to early intervention services detected from those screens. And even 6 months post-intervention, all of these practices were continuing to screen at 95 to 100% of the time. So we knew that this model worked well for lasting systemic change, and we wanted to apply it now to maternal depression screening. So this is what it looked like when we were working with these practices. As I mentioned, we were trying to integrate this intervention at all levels of the workflow. We called it like spreading the burden of screening across providers. The idea being, if you're just asking a doctor to do everything, it's less likely that they're actually going to do it because it takes too much time and effort. Whereas if everyone has a little task, not only is it easier to implement, but if one person misses it, the other person can kind of pick it up. So the workflow that we had was that the front desk would determine if a child was eligible for a screen, and if so, they would give out the screen for the parent to hopefully complete in the waiting room. Then the medical assistants that would do triage, so things like height and weight, would collect the screen. If the parent had difficulty completing the screen on their own, at that time they could review the results orally and then enter it into the electronic medical record that the physicians used. The physicians would then see the results when they were looking at the medical record, discuss them with parents, and make a referral if necessary. And then we were working primarily with federally qualified health centers, which have things called patient navigators. The patient navigator's role is to make referrals to other specialists. Typically, this is only within whatever health system that they're working in. So we actually had to get special permission to do referrals to early intervention, but then it made the most sense for this person to handle that role, and so they would handle those referrals. And as I mentioned, we kind of worked out the kinks during this first go around, and these were the steps that we found that we had to take working with each of these sites. We would start with an initial buy-in meeting with the practice leadership, then have an initial buy-in presentation for the entire practice, then do trainings for each aspect of the staff, depending on what their role was for screening, provide ongoing reminders at huddles and staff meetings, monthly sit-down quality improvement reviews, and then just keep doing those last steps for up to 6 months. I'm going to go deeper into examples of this when we talk about how we did maternal depression screening, but this is just the overview. And we knew that we wanted to apply this successful model to maternal depression because it is a pediatric issue. We know that nearly 20% of moms in the US experience maternal depression. So I know that the numbers vary, so we see somewhere between 10 to 20%, but it is not uncommon, as we like to say. And in fact, it is considered the most common medical complication during pregnancy and postpartum period. We also know that depressive symptoms can impair the mom's ability to develop a healthy attachment to their child, which then affects their child's development. So we know that children of moms who are depressed may be more likely to have impaired social, emotional, cognitive, or motor development, and thereby put them at greater risk for developmental delays. We also know that maternal depression has been linked to perinatal complications and early child developmental delays. So we know that infants may show more anxiety and restlessness, and that issues can go even into school age with underachieving in school and increased absences. And that's why maternal depression screening is recommended by the American Academy of Pediatrics and even by New York State Medicaid as a best practice part of a well child visit. So when we wanted to adapt this model for maternal depression, I want to lay out the logistics that we had, because I know this is always the #1 question after a presentation was like, well, how did you do this? How did you pay for it? So we did this through a 2-year grant funded project, and it was funded by 3 private foundations that they were either interested in mental health or early childhood. And the funding mostly paid for staff time because this is intensive technical assistance. So most of the work was just someone being there working with these practices. So I paid for a full-time practice coach. The person that we hired was an entry-level position right out of undergrad, and her role was really to be at each of these sites to provide the trainings and technical assistance, and then also put together the materials and really kind of name things that were super important to the success of the project. It also paid for half of my time to oversee the overall project. And then we had a stipend for a project consultant who, we were doing this project with the network of federally qualified health centers that we had worked at previously. There was a pediatric quality improvement person there. And we paid a stipend to kind of go above and beyond her role to help with the project. We also had some of the funding paid for us to obtain the permission to give maintenance of certification credit to any board certified physician. So there was this portfolio program that would go with many different board specialties where we could give them MOC credit. And that's really important because all board certified physicians have to have a certain amount of MOC credits every few years. And sometimes they're hard to get. So the fact that they could get it without kind of going out of their way was a real value add for them. Also, it was free for them. And we also obtained permission to provide CEUs to staff like medical assistants for their time as an extra carrot. And I mentioned that there was a full-time practice coach. So we did the project over the course of 2 years, although as you'll see, this looks only like a year because there was a lot of ramp-up time that I'm going to get into. But we would start with one site, work with them for a month or 2, and then start the second site as we continued working with them. So as you can see, the bottom, we started working with site A, and we actually ended up, even though we tapered off the TA, we still work with them for a while, but that's how we were able to do it, because as far as the practice coach's job, it was most intense in that first month. So they were able to provide a lot of attention in the first month and then kind of go every week with them and start a new site. And that's how that worked. So the preparation that I mentioned, we first spoke to other pediatric providers, mostly in New York City, that had some form of maternal depression screening in pediatric care to learn about their experience, best practices, and lessons learned. We also created a comprehensive resource directory. I'm going to show that to you at the end of this presentation, but we know from experience that if you try to get any professional to screen or detect for something, the first question they have is, well, where do I refer to? So we knew that we had to come in with a good sense of where people would refer to or what the step would be after screening in order to even have those initial conversations. And then we would have exploratory conversations with our partners. So as I mentioned, the sites that we worked with on this project, we had previously worked with on implementing developmental screening. So as that project was winding down, we would have conversations with them and say, hey, this is the next thing that we're looking at. What are your thoughts? What are your concerns? We also spoke with these federally qualified health centers had a joint behavioral health arm. So we had a sit-down meeting with behavioral health to talk to them about it, what their concerns were. And this really helped inform the plan that we were walking into meetings with. So we created a menu of screening options. So again, we had a workflow that worked in the past that we thought we could adapt for this, but we also needed to think about, well, what screens are we using and why are we using them? What would make the most sense for this population? So I'm going to walk you through our 6 steps based on an example of one of the family health centers that we worked in. Again, I know most of you aren't physicians, but these steps we've found are necessary for really any type of practice transformation across any type of practice. So whether it be a mental health practice, a childcare, wherever you're trying to do work, it takes this level of intensity. So we would start with an initial buy-in meeting with the leadership of the practice. So for practice leadership, this typically looks like a head physician, nurse manager, and a practice manager. We also knew that, these sites had patient navigators that were in charge of referrals, that we should have one of those there as well to make sure that we were taking everyone's considerations into account. So we would discuss the importance of maternal depression screening in pediatric care, the benefits of screening, the incentives that we were able to offer. So in addition to MOC, there's a billing code that they could use. Then we presented them with a menu of options for workflow, screening tools, and educational materials, and we'd walk them through that and help them make the decision about which options would make the most sense for them. And then based on that, we would create a plan. So now we had our plan for this is what the workflow would look like. These are the screens that we're going to use. These are the materials that we're going to use. We would agree on a timeline. So set a launch date for screening a month or 2 in advance with the idea that before then we have to do a staff buy-in meeting and train all staff. And also on our end, we have to help prepare all of the exam rooms with all of the materials and things needed. And in this case, there also needed to be changes made to the electronic medical record. So we needed to have a little bit of lead up time. So a note about the options that we presented. So when we were looking at screening tools, we were coming at it from our experience doing developmental screening. In the practices that we worked in, their populations were primarily non-English speaking, or English not being the first language of most patients, with Spanish being the #1 language spoken. And for a lot of families, they struggle with literacy. And so for developmental screening, that's why we had that 2-step process of giving the screen in the waiting room, but then having the option of a medical assistant reading through the screen with the family. And if the medical assistant didn't speak the language of the family, we had some audio recordings that they could play that would walk the family through the screen. So that was something that we came into this with, but when we were looking at the literature, we came across something interesting. So looking at screening in different formats. So the first being interview, so someone going over the questions with you and getting the answers one-on-one versus a paper screen. The interview actually yielded less positive screens. So doing an interview, only 5.7% of screens are positive. And again, we would expect at least 10% of screens being positive, maybe up to even 20%. Whereas the paper screen actually yielded 22.9% of positive screens. So the reason for this is that potential, like with something like depression, especially maternal depression, which a lot of people carry shame around, the anonymity of the paper screen might have made it easier to be honest about the answers, whereas it might have been a bit intimidating one-on-one. But we also had to consider literacy. So how do we balance that? And so what we came up with was that we were going to do both. So we would give the paper screen at first, and then someone would review the results orally and allow for an opportunity to change the answers or whatever, or make sure that they understood. Then we were looking at screening tools. So there were two, or really 2.5 screening tools that came as the best options. So most people may be familiar with the Patient Health Questionnaire 2 or PHQ-2. It's just 2 self-reported items about mood, and it takes less than a minute to complete. So over the past 2 weeks, how often have you been bothered by little interest or pleasure in doing things, feeling down or depressed? Based on that screen, you may then be given a more comprehensive screen, the PHQ-9, which goes more into depth to look at the severity of depression. The issue is, if you look at some of these items, and we're thinking about maternal depression, so someone who's pregnant or maybe is a new mom, trouble falling or staying asleep, I feel like every new mom would answer yes to that, like nearly every day, and therefore I'm feeling tired and have little energy, and therefore I have trouble concentrating on things. So it's not particularly calibrated to the experience of being a pre or postnatal mom. That's why we also looked at the Edinburgh postnatal depression scale, which was specifically made not only to detect maternal depression, but also maternal anxiety. And so it's, again, it gets rid of those constitutional questions. So when we were looking at our options between the PHQ-9 and the Edinburgh, we saw that they both took about the same amount of time, 5 minutes to complete. Both had a low required reading level, both were easy to score. But the Edinburgh includes anxiety, so it captures this other aspect of something that we wanted to pick up, but it also excludes those constitutional symptoms, so like such as changing sleeping patterns that would have been common. So what we decided to do after a lot of back and forth, and this was a very unique decision, but all the practices preferred the Edinburgh, but were afraid of implementing it because it would take too much time and maybe be too intensive. And so the compromise that we came up with was starting with the PHQ-2, and then if the PHQ-2 was positive, rather than triggering a PHQ-9, it would trigger the Edinburgh postnatal depression scale. So this is what the workflow looked like. I do also want to note, we did this in pediatric practice, and that's what I'm focusing on, but we also worked with the OBGYNs. They were already doing the PHQ, and so we just worked with them to strengthen the process to make sure it was always happening and provide more materials. But I'm really focusing on what we did with pediatrics. So the plan was that the front desk staff would give out the paper PHQ-2 screen to the mom, which we had translated in multiple languages. And this was going to be during any well child visit if the child was up to 12 months old. Then when the medical assistant would take that information, they would briefly explain why we did that and scores the PHQ-2, and that's an opportunity to review the results as well. So if the PHQ-2 was negative, record the results on the chart, continue the visit as usual. But if it's positive, give the mother the Edinburgh screen. Then that would be entered into the electronic medical record. The doctor would review it. I want to put a big caveat on the next part I'm going to review. The number one thing that we would get when we were talking to physicians about doing maternal depression screening was that they were scared. They were scared of what to do. And so that's why we really had to come up with a workflow based on different results. But this was all guidance based on literature and best practice. And we always put the caveat, you need to use your best clinical judgment, and you need to listen to the family and what they need. So if the score in this case was 4 or less, we would consider that like a negative score, and you can talk about maternal depression but continue the visit as usual. But if the mom is indicating more concern and wants more help, absolutely help them in other ways. So that's the caveat. But we would actually start by looking at question number 10 on the Edinburgh screen, which asked about self-harm. So that was the risk assessment. So if that was positive and you reviewed that and you did a risk assessment with the family, as would have been procedure regardless of the screen or visit, then they were going to follow their typical procedure, which was to make an immediate referral to emergency care. If not, we're going to continue with the other prompts. So if the score is 4 or less, the idea is that the patient likely doesn't have depression, but you want to talk to them about, like, here's why we did this screen. Here's the information for the Postpartum Resource Center of New York. I encourage you to call them if you have any concerns, and to talk to me if you have any further concerns. And then maybe that's the end of the conversation. They continue the visit. If the score is 5 to 9, the patient is at increased risk. So you're going to provide the info and talk to the family about a referral. And then a score of 10 or more, the patient is very likely depressed. We want to, again, talk about it, give information. It's ultimately up to the patient regardless whether they take a referral. We really encourage a referral at this time. And because they had integrated behavioral health, trying to get someone from behavioral health to actually come to the meeting room at that point and make a connection with the family. All right, so with that plan in place, we'd have a buy-in presentation with the entire staff. This is always really crucial, staff-wide buy-in, because in the case of these practices, and with a lot of other professional places, decisions are made from the top down and just kind of sent down. And so, you know, you come into work and you're told you have to do this new thing and there's no discussion about it or whatever. And because there's a lot that needs to be done. But we knew with a change like this, the staff needed to understand why it was critical that we were doing this and how they were actually a really integral part of the process. So we'd start with our pitch about maternal well-being and child development, go over maternal depression screening, talk about common barriers and opportunities, what the project was going to look like, and talk about how to talk about results and making referrals. And the idea was twofold. First of all, we wanted to get feedback because, you know, staff may have considerations that the leadership wasn't thinking about, and that may tweak what the plan is going to look like. But the other part is doctors were going to be the ones that were reviewing the results, but doctors, I mean, depending on the doctor, that might not be the person that the patient feels most comfortable talking to. Maybe they have a better relationship with the medical assistant, or maybe they had, you know, talked to the front desk staff and they feel comfortable talking to them. So we wanted everyone to feel comfortable enough to be armed with information to provide a family should that need arise. After this staff-wide buy-in, we would do small group or individual trainings. So this was important, and this comes up a lot in our work, again, in practice transformation, regardless of the setting. The leadership often thinks that that staff-wide meeting is the training, and it's absolutely not. It is an overview, but we need to sit down with each part of the staff and walk them through what their new part of this process is. So typically, like, if we could get the group of front desk staff or the medical assistants together and actually walk them through what their new role is in this process. So we would try to do that. If there was already an existing meeting that we would just show up at, this would only take like 10 minutes. And we didn't want to wait to make sure that everyone was there because that would delay things. So we would try to get the most people at once as possible, but then we'd have a list of the people that we needed to train. And so as we missed people, we would go find them and do an individual training as needed. Ongoing reminders, also really important. Despite all this training, you know, think about your own work. You have so many things going on all the time. Think about what happens in these practice visits. They're responsible for so many different things at so many different visits that they're absolutely going to forget. It's going to happen. So we would place strategic reminders throughout the practice. There were computers in every exam room. So we printed out these little cards with a very rudimentary overview of the steps to take, and they were laminated and they were taped on the monitor. We would also show up every week to do site visits. So most medical practices have things called morning huddles where the staff will come together for about 5 minutes to go through the cases for the day. We'd show up for those. We'd bring food and coffee, and we'd literally just take 30 seconds to remind people about the project and say, hey, you know, I'll be around for the next hour if you have questions or have any feedback for me. And we would do that at least once a week for several months. Then once a month, we would sit down with practice leadership or whoever was going to be in charge of this. we would have them run a chart review. So we didn't have to do anything, and so therefore we didn't need to have like approval because we weren't the ones looking at the charts. We were teaching them how to do this, and the idea is that they should be doing this even after the project is done. But they would run a report of eligible children, so children that came in for visits where the screen should have been given, and then we would go through, and sometimes it would be random. So like if there were 30 children, we don't need to sit and go through 30 charts, but we would pick at random and go into the chart and say, was the screen done? If it wasn't, why not? Was there a common staff member in all of the visits where there wasn't a screen? What was going well? Was there a staff MVP that we could celebrate at the next monthly staff meeting? So we would look at all of that, and then we would put together a quality improvement cycle, which I'll be going into a little bit later, to make a plan to improve it, because there's always room for improvement. And then we discuss the results at least once a month. So showing up to monthly staff meetings and just having 5 minutes to talk about the project was also key. So I mentioned talking more about quality improvement. For anyone who's not as familiar, quality improvement processes come in many shapes and sizes, and they go by many different names, but there's a common goal. We just want to improve and assure safety, quality, and efficiency. In this case, in healthcare, but we use quality improvement in every system that we work in, so it's applicable across the board. What's common in healthcare and what we use in this project are called PDSA cycles. These are process improvement approach to evaluate change quickly. So you do cycle after cycle after cycle, and do small tests of change. So this is what it looks like, and I'm going to talk through it. And for anyone who is new to this, it's going to sound like very common sense, and that's because it is. But doing it formally is actually a really helpful process. So the P of PDSA is plan. So what is the plan? So what's the objective? What are your predictions? And what is the plan to carry it out? Then you do the plan. So we carry out the plan, document any problems, study it, look at the data that you have, compare that to what you expected, summarize what was learned, and then act. What changes need to be made, and what are we gonna do for the next cycle? So when we started screening, we had a plan. And so that first monthly sit down, that month was doing the plan, and that monthly sit down was the studying of the plan and looking at it. Did it work or not? What needs to be changed? And then we would figure out the next steps for the next PDSA cycle. And we would do this over the course of several months. So it may take several PDSA cycles and several months to get the process manageable, and that's why it's kind of like a cycle upward to changes that result in improvement. This is what a PDSA worksheet could look like, and we did this with everyone. And again, it seems tedious, but it was actually incredibly helpful when you write it out like that. So we'd start with the overall aim, what our plan was, who was responsible, when it was going to be done, what our prediction was. So what happened? So in this case, the screening increased from the previous month. So it was at 60%, it went up to 94% because we made these different changes. And so we had some suggestions based on analyzing the results, and then we made our next step to act for the next month. I think, hold on, I just wanna, here we go. I wanna show this slide. So as I mentioned, we were working with several different practices over the course of time. And this is the reason why these monthly PDSA cycles and ongoing are important. For everyone, you'll see everyone started at 0% because no one was screening during pediatric visits for maternal depression before the intervention. And then we'd go up, and they typically are at 100% because there's all of this energy, there's a lot of talk about it. So month one is 95 to 100% screening. And then every one of them drops precipitously in month two because everyone gets a little bit complacent and they go back to their normal practice. And that's why it's so important to do these changes over time. And I mean, look at the blue one. We were working with them the longest, and yet a few months in, there was a major drop. And we were able to identify, oh, wow, this is when they had, it was a the practice went through a training hospital. So all of the new residents were coming in that summer. And training on the screening was not part of the resident curriculum. And so we had to take a step back, train all the residents, and then talk to the residency curriculum training manager about integrating this into their curriculum. So other methods of evaluation that we used: pre and post surveys, the chart reviews that I talked about, informal qualitative feedback, and running billing codes. So pre and post surveys. Every time before we did the staff-wide buy-in, we would do a pre-survey just to get a sense of what their attitudes were towards maternal depression screening and their understanding of how their practice did it. And then we would also do it at the end of the project period. We would give the same survey. So some noticeable responses. In the pre-survey, there were barriers. The top barriers listed were they felt that parental literacy issues would be a concern. There would be lack of parental understanding and lack of time. And knowing this in advance allowed us to tailor our buy-in presentation to address those barriers. So chart reviews. I mentioned before, this is what we were doing every month, and we were looking at the number of moms screened out of the number of moms that were eligible for screening. So who should have been screened versus who actually was. Then we also tried to look at, all right, how many positive screens were there? What were the scores for those that actually did the Edinburgh screen? If there were referrals made, what happened to them? Where did they go? So we tried to track patterns when looking at these charts in who was administering the screen, what happened after. Because typically, as I mentioned before, sometimes you would see there was a month of like, wow, only 50%, screens were only given 50% of the time. And all of the ones that were missed was one staff member. And that staff member just forgot and needed a new training, or maybe, you know, like something else happened. But that allows you to figure out what your plan is to address the issue. Informal qualitative feedback was huge. So this is the benefit of having a third-party practice coach doing the work. People would tell us all sorts of stuff because we were not employed by the practice. And so we could not get them in trouble. So they, you know, we would, and that's also the benefit of being there regularly. So let's say that we're there a few times a week at the beginning, or like once a week, they get familiar with you, and you just check in with them. You're just kind of like hanging around the staff room and someone comes in and you say, hey, you know, like, how's it been going with screening? And, you know, one example is we had a site that was like at 100% screening implementation for months. And I thought we were going to finish with them. And then I speak to this MA and he was like, oh, it's adding 10 minutes to the visit. And I said, whoa, that's not supposed to happen. What's going on? And the issue is that he didn't speak Spanish and the family did. And so the idea of the interview, he would need to use a translation line. And that's where we said, okay, we need to address this. And so we came up with audio files that can be played that were in Spanish to make the visit shorter. So it's highly informative. It also keeps the staff engaged. They realize that we actually do care and they feel like they're a part of the project. As I mentioned, very honest feedback, especially being a third party. So it allowed us to determine what should go into the PDSAs based on that feedback we were getting. Because again, if we were only looking in the example I gave at the chart review, there was nothing to change. We were at 100%, but it's not sustainable if it's adding so much time and burden to the staff. So we had to address that. So billing codes. So at the time we were using the 96161 billing code for maternal depression screening. This had pros and cons with actually running reports. It was the easiest way to run a report to see if a screen was done, but the issue is that what we realized in doing the chart review and then trying to run a billing code report, or trying to have the practice run a billing code report, is that they did not match. The billing code report said that only 50% of screens were given, but that month we had gone through every chart and we knew that a screen was given. So that actually helped identify that there was an issue with like the billing code being linked. Like there was something in the electronic medical record, but I'm glad that we didn't just rely on the billing code report. All right, let's talk about barriers to implementing change. Again, this presentation is specific to our work in pediatric practices, but all of these barriers we've seen in all different types of settings. So, you know, mental health settings, social service settings, So I just want to talk through how we got through them. As I mentioned, we did a pre-survey, so we knew what the concerns were in advance and we were able to address them right at the start. So some of the concerns including adding too much time to the visit. And so that's how we made that compromise of starting with the PHQ-2 before going into a more comprehensive screen. So that really limited the number of more intensive screens and therefore adding more time to visits. Literacy and cultural issues were also a concern. These are issues for like every screen though, it's not just maternal depression. We were able to provide different languages and attend to cultural issues as much as possible. Another big concern was handling an emergency, and I found this very interesting. So when we sit down and talk about this, invariably the first question was like, well, what happens if the mom, like if we ask the mom how she's feeling and she says she's suicidal? Like that was a reason not to ask the mom how she was feeling. But we would say, you know, you're a health practice. You already have an emergency protocol in place for this. So this isn't new based on this screen, and just reminding them that there were already strategies to lean back on. And also how unlikely that scenario would be. Pediatricians, some of them would say, you know, the mother is not my patient, which is absolutely true, but that's why we had to make the case for explaining the connection to child development, that this is really part of you taking a social history on the child that you're working with, and that it's best practice for a reason. Another huge one, and this was very interesting coming in as with a mental health background, we're afraid of asking a question that we're not prepared to handle the answer for. So this is why we spend a lot of time arming them with referrals and steps to take if the screen is positive so that they felt comfortable. We always said, like, you need to feel, you need to ask the question in a way that you're not afraid of getting the answer, because we knew from other experiences that there were some physicians doing maternal depression screening, but the way that they would do it is, oh, you're not depressed, are you? Because they want the answer to be no. And so you're completely cutting off that conversation. And we would hear that from moms that we spoke to. So the idea was, we want you to feel comfortable in receiving an answer of yes. And so that you can ask the question in an appropriate way. And then we also showed them stats from other sites. We're like, listen, this is a problem, but it's not going to be every mom that you ask this of. It's about 10 to 15% of moms. And that's why it was really helpful that we had spoken to those other sites that did screening before, because we used their data to show that. With the electronic medical record, there were concerns about complicated medical history situations and, like, you know, having to share this medical information. So we explained how other physicians dealt with that. And then again, reminding them that this isn't very common. I'm glad that we have a plan to address it, but like, I think that shouldn't be the barrier to doing this for everyone. And finally, adding the screen to the electronic medical record. It typically can be done, and quite easily if you talk to the right people. And in fact, a lot of medical record systems now have existing templates for maternal depression screening that you could just add. So my international disaster psychology background had me bringing this to work. This is a visual from the World Health Organization about referrals. And this was one of the big things that we were taught, was that, you know, not everyone, even if there is a mental health concern, not everyone needs a psychiatrist, right? And that's where this training really came to be, is that a lot of systems like this don't exist in many places. And so we have to rely on more informal services. And so this is the pyramid of referral that we use now all the time to talk about this. So first one, everyone benefits from psychoeducation about self-care. So we can start there with everyone. And that's why regardless of the screening results, all moms were to get information about the Postpartum Resource Center of New York, and then another document that talks about, you know, like, this is what maternal depression is, and this is why you should talk about it if you have it, and like, here are the steps you should take. Everyone got that. And then, you know, maybe there's a little bit of concern, sometimes informal community care. So thinking outside of the box, where maybe, you know, mom has a low EPDS score, and they really just, like, the main concern is that they're socially isolated because they're a new mom and whatever their situation is. But even getting mom into like a breastfeeding support group, may be enough in that case to help support mom in the way that she needs to be supported. She doesn't necessarily need specific maternal depression resources. And then mental health services through primary care, so kind of a general behavioral service like they offered. And then that next step, well, maybe it's a little bit more intense, and then we want to think about more specific, like someone who specializes in maternal depression or a maternal depression support group. And then only in the rarest of cases would someone really need intensive psychiatric treatment. So we use these colors, look at them, it's almost like a stoplight-ish. So we used this to guide how we put together our referrals. So I mentioned we put together a massive resource list, and we color-coded everything based on this that we explained to everyone before we gave them the packet of resources. So we started with, here are things that are just good that you can give to anyone, even if they're saying that they don't want any help. You could say, well, here's a number in case you want help in the future. It's not going to hurt. So we had things like common helplines. So the Postpartum Resource Center of New York was something that we gave to everyone. And then that next level, self-care, education, and support. So maybe a little bit more. So maybe we would try to connect them to the Mitch program. Again, things that are not necessarily specific to maternal depression, but can provide supports in other ways to moms. Then a little bit more intensive support groups, individual services, programs that are a lot more specific to maternal depression. And then finally, at that highest level, where the least amount of moms would need help like this, are emergency care and intensive psychiatric care. Here on Long Island, where we were doing this work, we actually did have a perinatal psychiatry unit that could be utilized. All right, so some lessons learned, again, applicable to every practice your information in any setting, not just the medical setting, because we've done this a lot and the lessons are always the same. I start my story with what I call for want of a staple. And the long story short is we were doing screening implementation at a clinic. And at this time I was working with 5 different sites at the time. And I was really busy driving around Long Island trying to do this. And so I had brought them copies of the form that they needed for referrals. And I didn't have time to staple them together because they weren't already collated. And so I left them with the staff and I said, hey, there's 2 papers, you just need to staple them together, but that's the form that you need. And then a little over a month later, I get a phone call from them and they were having some big meeting and there was an issue with the referral process. And once I figured out what had happened, I realized they were only using 1 page of the form. And so the referrals weren't working because they didn't use the other page because they didn't staple it. The point of that story is that having that outside practice coach whose role it is to do these things, this is why it's so important, because the day-to-day realities of work in this case of practice keep people from freaking stapling paper together, then that ruins things down the line. And so having that intensive, providing all of those materials is pretty key to get that started. One-off trainings are not enough. I say this lesson all this time, and I learned this lesson all the time. You can't just have a presentation and then assume that practice change has happened. And this actually, an example of this is our maternal depression project. When we started and we talked to them, they told us that they were doing maternal depression screening. And we were like, oh, that's so weird. We spoke to the physicians. None of the physicians say that they were doing it. It was the higher ups that said that it was being done. And when the higher up ran a report and looked, she realized maternal depression screening wasn't being done. But the reason she thought it was because they had a provider meeting and she said, hey, I added a maternal depression screen to the template, and so you should do that now. And that was the end of the conversation, and she assumed that it was enough, and it wasn't. And that's why you can't be afraid to repeat things and repeat them and repeat them. Even 6 months working with the site, we'd be repeating things that we said on day 1. But it also showed that people were actually internalizing it at that point. They weren't just nodding their heads along. Also for maternal depression screening, who asks the question and how often makes a difference. So as I mentioned, sometimes the doctor is not the most trusted person. And I've worked with doctors where I would think, if you were my doctor, I would not feel comfortable talking about my mental health with you. But the medical assistant, I might. And so the idea that you're preparing the entire staff to have these conversations as needed. Electronic medical record training is essential. Practice champions and leadership engagement is critical. We don't like to rely on the idea of one person in their practice being the practice champion. That's so great, but what happens if they leave? And also the rest of the practice often thinks that this is like that person's project, they don't own it. So the idea of cultivating practice champions across the practice. So we would often get buy-in from unlikely places, like a medical assistant who had maternal depression, and so was very invested in the project. And that's why it takes a whole village. You can't do this without the support staff. And don't forget about new staff. Just because you trained everyone, there needs to be a plan for onboarding new staff into the process. And that's why, again, adequate funding is essential. So we used it primarily for personnel, but also to buy food for staff, which made us their favorite people. It was important, and materials and printing, and then also the money it costs to offer MOC credit. So I am basically at the last 5 minutes. I'm just going to talk about opportunities to move forward, and then we'll take questions. So Docs for Tots, we put our developmental screening toolkit for free online for practices to try to utilize. And as I mentioned, even though it's for developmental screening, we found that everything is applicable regardless of the screening you're trying to implement. We also now have a maintenance certification credit course available online for only $100, which is cheaper than most MOC credit courses for anyone who's board accredited in American Board of Pediatrics or Board of Family Medicine. It focuses specifically on developmental screening. However, the same methodology can be used for maternal depression screening. So any physician that wants to do that would then kind of be equipped with the knowledge that they need for maternal depression screening. We also offer TA packages for any site that wants to implement this but needs that outside support. We have a really low cost option. And then coming soon, we're trying to, we've put together a curriculum to train practice coaches. So the idea that you wouldn't need to work with us, we would train someone at your practice or really whatever setting that you would then be working with sites to implement this, and we would train them to do what we do so that you'd be prepared to not only implement or help implement maternal depression screening, but also developmental screening, ACEs screening, etc. So I'm going to stop and take questions. And here is my email and my cell phone number. If we don't get to answer your question, please feel free to contact me after.
Well, Melissa, thank you very much for your wonderful presentation. And it's really very important, the best practice model that you shared with us. So thank you very much. We do have some questions already that were shared in the chat. But right before we get to that, and I know we will run a bit over our time here, but for those people who can stay, please stay with us if you can. So let's see, we want to ask one last question. So regarding the material of this webinar series, we want to use this webinar series as a way to bring together professionals in the field of perinatal mood and anxiety disorders and further continue to grow this network. So if there are some topics you would like to see in this webinar series, please add them to the chat now or before logging off at the end of this discussion. So please feel free to type that in the chat. So right now, Melissa, let's see, the couple of questions we already had that were in the chat for you was, first off, do sites have a script that they use when handing out the screen to the family?
Yes, so we type instructions that were included so that we would go over the script with everyone in their training, but we also had it on the top of the screen so that if someone felt uncomfortable, they could just read from the instructions.
Okay, thank you. Second question. With your program, were advanced practice providers such as physician assistants, nurse practitioners, were they incorporated also into the program for scoring as well as sharing results that could be discussed with patients and families?
So they absolutely could have been if it was relevant, but in these particular practices, they didn't really have physician assistants and the nurses, their roles in the practices like weren't conducive to the screening process, and that's why we had actually thought that would be the case at the beginning. But there's no reason why those types of staff couldn't be if that was relevant to that particular practice.
Okay, so you could see definitely incorporating them. Okay. Next question. How do you decide when, let's see, when a screening tool is given? Is it given to every new mom, or is there decision who gets screened?
Universal screening. So every new mom, and this was another back and forth because to make it easier and to not remember which visits, we just said anytime it's a well child visit before the age of 1 year, give it. And there are a bunch of well child visits, but in this population, a lot of families wouldn't go to all of them. And so we said, if you're giving the screen, 6 times, you're giving the screen 6 times. That's great. That's 6 opportunities to talk about this. So that's how we saw it.
Great. Okay. Also, in your program, did you consider incorporating peer support at all to further help break through any stigma barriers?
I mean, we offered the Postpartum Resource Center of New York, and we would really encourage the provider that was giving that information to talk about how there's peer telehealth support, but that was the extent. The role of this project was to implement screening and referral processes. So peer support would be a great referral resource, but it wasn't in the scope of the practice or the project to really look at that, or at least the way that it was designed.
Okay, thank you. So at this time, we'd like to invite people to feel free if you would like to share your video screen and unmute yourself and ask Melissa any questions. So feel free at this time, or if you feel more comfortable including any more questions in the chat box.
Sonia, I do have a couple of questions that have come to me directly that I don't mind sharing. So one of the questions is, what do you think about using the GAD-7 as anxiety screening?
I'm not as familiar with it. And for us, the screen itself, so I would just go through like the considerations, right? So the considerations are, how much time will it take? Is this going to get the information that you really want to get to? And is it appropriate for the population? And if all of those things are answered, then absolutely, you should implement that. And then like things that we've done in the past too are just choosing one visit to implement something at. If you have enough patients coming through for that visit that you can have enough of a sample to test it out, see how it works. Is it identifying anyone at the rate that you would expect to? Is it easy enough to implement? Those are the things that we look at for if we're thinking about sustainable change.
Thank you. I have another question here. Do you have any thoughts or can share any successes regarding screening via telehealth?
That's a great question. And so not as much, because this intensive TA we haven't given in the past year or so. And we did follow up with some of the sites that now screen because of working with us over COVID. And I know for the sites in question, they all used the same electronic medical record that wasn't really well adapted for telehealth visits. And by that, I mean, there was no way for a patient to self-complete a screen beforehand, although that was something I spoke to them last summer, and that was something that was going to change, but I haven't spoken to them about it since. I think one of the main points that we try to drive home with maternal depression screening was that using a standardized screening tool is, that's what we're trying to do, that's the gold standard. But even if it's not getting, even if someone isn't honest, like, so say someone was suffering from depression and they weren't honest on the screen, you'd want to open up a conversation and introduce this as a topic that is safe and important to talk about during the visit. And so in that way, a telehealth visit will still allow you to do that. So even if you aren't able to do the screen because of the logistics, bringing it up and saying, how have you been doing? And even if mom says, oh, I'm fine, just providing some anticipatory guidance really around maternal depression, saying, you know, it's not uncommon to feel X, Y, and Z. And if you are feeling that way, I can give you some resources or we could talk about it. Like, just let me know. And that is really what we were trying to get at. And so that can happen during telehealth is what I mean.
Thank you. It looks like that's all the ones that I have directly sent to me, Melissa.
Melissa, I have a question for you.
Yeah.
What do you, because I had to step away from the meeting for a minute, so I don't know if you've already mentioned it. What are you utilizing as standardized screening tools?
So the sites that we worked with on this project, they use the PHQ-2 as the initial screener, but then rather than triggering a PHQ-9 if it was positive, it would instead lead to an Edinburgh postnatal depression scale.
Okay. Okay. So they went to the PHQ. They used the PHQ-2 just to screen out, so to speak. And then if it was a positive, then they would go to the Edinburgh as their next step. Okay.
Correct. And that was the compromise we made because there was a lot of concern around adding too much time to visits and also like literacy and everything. So the PHQ-2 being so brief, being something that they were already giving at different visits, it was the best way, as you said, to like screen out so that not everyone would need to go through the entire EPDS.
Okay. I'm asking because we're already at our organization, which is the Lower Hudson Valley Perinatal, we are already screening all about pregnant, postpartum, actually screening all of our clients that come in. Whether they have children, don't have children, or in between pregnancies, it doesn't matter. They're all getting screened. But I just wanted to know which, we're utilizing the Edinburgh for all of them.
Mm-hmm.
So I just wanted to know how you were doing it, if there were other tools that we needed to be using. And I am familiar with the PHQ-2 and the PHQ-9, but it's trying to figure out, do we really need to use them or we can stick to the Edinburgh?
Sure. And so that's such an interesting point. We've done practice transformation with sites that are already screening. And the idea is that there's always room for quality improvement. So if you're using the Edinburgh at all of these visits and that's working, that's wonderful. My question would be like for quality improvement, are you doing it, I would say like at least 85% of the time, because if not, then maybe it's, okay, do we need to be using something that's easier to implement in order to still be addressing this more regularly with families? But if you are, if it's working for everyone as part of the process and you're doing it more than 85% of the time, then that's great and keep doing that.
Okay. Thank you so much.
Mm-hmm.
Any other questions for Melissa? Brittany, anything else you have?
I think that's it. You're getting a lot of thank yous. It's very informative.
Yeah.
I had my email on the other slide, but I mentioned some of the specific, offerings for this, and here are some direct links, but I bet Brittany will be sending this out to everyone too.
Yes, I'll make sure that we share these. And just as a reminder, the PowerPoint as well as the recorded audio today will be posted to our website at the Schuyler Center. And they should be up within the next hour if anyone wants a copy of those.
So thank you for everybody for joining us. Thank you, Melissa, for this wonderful presentation. Again, for the very, very important work of Docs for Tots. And we're very excited that everybody could be here today, and that also that Docs for Tots, as you shared, will be having, continuation with this program. So thank you very much. And we invite everybody to, again, join us with our series as we continue to move forward here. February 12th, we will be highlighting through the March of Dimes. They will be presenting on the implicit program, an innovative interconception care model, which will be presented by Dr. Scott Hartman and Darcy Dreyer of March of Dimes. So thank you again, everybody. Have a great day. And again, thank you very much, Melissa.